Good morning, everyone. You are very welcome to the HSE Tobacco Free Ireland Update webinar. The panel would be delighted to receive any questions you may have. Please use the Q&A feature located at the bottom of your PC or laptop screen. If you are using an iPad, you will find this feature located at the top of your screen. Now, without further ado, I will hand you over to your host for today, Martina Blake, lead for the Tobacco Free Ireland programme in HSE Health and Wellbeing. Thank you.
Thanks very much, Jean. Good morning, everybody. You're all very welcome to this morning's webinar, and we're going to take you through the most up-to-date information in terms of tobacco control here in Ireland. We'll also talk to you a little bit about e-cigarettes and vaping and non-medicinal nicotine devices, and also we'll touch on cannabis and synthetic cannabinoids, and we'll have a Q&A discussion at the end. So you're all very welcome to put any questions that you might have in the Q&A feature, which you'll see at the bottom of your screen. So I'm going to just take you through, introduce who we're speaking to this morning. So I'm just going to share my screen. Just bear with me for a second. So I'm going to introduce you to my colleagues who are going to, sorry now, just fiddling around here with trying to get the proper display. Perfect. I think everybody can see the full screen now. So I'm going to talk later on to Susan McNichol. Susan works as a stop smoking advisor in North Dublin, and she's going to give us an insight into stop smoking services and what you might expect when you come through a service. We'll then be talking to Darina Carr. Darina is our national campaign lead, and she's going to talk to you about best practice in terms of quit campaigns, how we develop those, and how we evaluate them and use them to kind of motivate and encourage and engage people in quitting smoking. We're then going to speak to Dr. Paul Kavanagh, who's a consultant in public health medicine and has been an advisor to the Tobacco Free Ireland programme for a good number of years. He's going to give us an overview of stop smoking medication and what's best practice in that space and how stop smoking medication has changed and improved the delivery of stop smoking services over the last number of years since we introduced it free a couple of years ago, or in the last year and a half. We're then going to hear from Edward Murphy, who works with me in the Tobacco Free Ireland programme, and he's going to talk about e-cigarettes. And we will also then be joined by Professor Bobby Smyth from Social Inclusion, who's going to discuss cannabis and synthetic cannabinoids. And then we'll have an open panel discussion with everybody where we can get your questions and answer your questions live. So just to kind of remind us where we're at and why we want Tobacco Free Ireland, we have a government strategy that has a goal and a strategy to deliver a Tobacco Free Ireland. And what we mean by that is to have a smoking prevalence of 5% or less by 2025, which is next year. And I'll take you through some of the stats in a little bit. We're not there. We have reached it for children in terms of we've reduced smoking prevalence among kids, but not among the adult population, and it's remained stubbornly high at 18%. But we do have that goal to reach that, and lest we forget, we know smoking damages literally every organ in the body. It impacts our mental health and increases our risk of developing mental health problems, impacts our circulatory system, risk of heart disease, risk of stroke, risk of diabetes, osteoporosis, fertility, things that you might not know about in terms of smoking. It literally affects every organ in the body. So it's hugely damaging. A product that, if it's used as intended, will kill 1 in every 2. So those are the odds in terms of smoking and the risk that it poses. Just in terms of the annual impact of smoking, so 6,000 deaths a year, 100 deaths a week. So that's 100 families who lose a brother, a son, a father, a mother, a wife early. from tobacco, and they lose usually 10 to 15 years of life, and the years of life prior to that loss is usually one of suffering and one of chronic illness and in and out of hospital. A huge burden on our health service in terms of cost and in terms of bed days, over 21,000 bed days, 33,000 inpatient hospital admissions, purely in there because of smoking related disease, 309,000. So those figures are kind of staggering, really, when you look at them. 460 million cost to the health service. And a lesser known fact around tobacco is that 55% of all litter is tobacco related litter. So a huge environmental cost to the state as well and to our local authorities in terms of cleaning up tobacco related litter, and more recently vaping and e-cigarette related litter, which is more complex to manage and to dispose of correctly. So what do we do in the HSE? I mean, in terms of addressing tobacco control, it's wider than the HSE in terms of the stakeholders that are involved or that need to be involved in order to achieve a tobacco-free Ireland. But for us within the HSE, we work in a number of different areas. So we work in terms of our mass media campaigns, developing evidence-based, cost-effective and award-winning mass media campaigns. And you'll hear from Darina later on in terms of how we go about doing that. Our environmental health colleagues monitor tobacco legislation and do things like test purchasing. And monitor smoke-free legislation, and now recently e-cigarette legislation as well. We're trying to improve tobacco-free environments. We're trying to build a better health service, a smoke-free health service, and we appeal to the public not to smoke on our health service grounds. That's a hugely challenging area, and we often find breaches of our smoke-free policy across our hospitals and across our primary care centres. But we appeal to the public not to smoke, in our buildings and outside our buildings. And the reason is because it's we're trying to portray, a healthy, safe and clean health service, and obviously not cause difficulty for people in terms of secondhand smoke as they come in to receive healthcare. But we know also that smoke-free environments in the wider space help to denormalize smoking for the general population, for children not to see smoking and think that it's normal adult behaviour. So we're working with our local authorities to promote smoke-free spaces, smoke-free beaches, smoke-free playgrounds, all of that. And the main thing, I suppose, is around identifying and treating tobacco use through our stop smoking services. And we'll be hearing from Susan later on in terms of how we deliver and the types of stop smoking services that we have and supports that we have. All of this is underpinned by research that we commission regularly. We monitor our services and the programs that we deliver and evaluate. And our idea is to try and prevent, obviously, smoking initiation, so prevent young people from ever taking up the habit of smoking and promote smoking cessation. So in terms of smoking prevalence, this is some stats in terms of smoking prevalence. So in 2015, we had a smoking prevalence of 23%. We had a bit of a drop in 2018 when it reduced to 20%. But in the last 4 years, it has remained stubbornly at 17, 18%. So we haven't managed to reduce smoking prevalence to anywhere near what we're trying to achieve in terms of a tobacco-free Ireland. So we really need some blue sky tobacco control thinking in order to achieve that aim. E-cigarette use there has grown. It's currently among the general adult population at 8%, and obviously way higher among younger people in terms of 15 to 24-year-olds at 18%. This is just some stats in terms of prevalence by gender. So you can see there, male smoking, it remains stubbornly high and hasn't dropped as significantly as female smoking. So more women have quit in the last 7-8 years than men. So we've higher smoking prevalence among men. 14% smoking daily, highest smoking rates, not surprisingly, among young people, 25 to 34-year-olds. Higher rates among those who are unemployed. And Paul will be talking a little bit about the gap between those who are deprived and those who are more affluent in terms of smoking prevalence, quite significant. So among unemployed at 40% and those who are employed at 17%. 8% of the population smoking or vaping, and more women than men vaping in 15 to 24-year-olds. So the opposite from smoking. So how are we doing in terms of children? We definitely have made good improvements in terms of reducing smoking prevalence among our teenagers. There's two different studies. This is the data from Health Behaviour in School-Aged Children, a European-wide study with an Irish arm. And in terms of ever smoking, we've reduced to 8% of 12 to 17-year-olds, and current smoking, that's smoking in the last 30 days, now down at 5%. In terms of vaping, however, we've seen a lot of change in this space. Adults' use of e-cigarettes from 2016 has grown from 3% to 8%. Very high use in under 25s from 10 to 18% in 1 year. So that was a significant jump. And in terms of vaping, there's two studies that we refer to. That HSE study that I just referenced, which looks at 12 to 17-year-olds, done every 4 years, has risen from 9 to 13%. And then there's another study, SPAD, the European Study of Drugs and Alcohol, that looks at 15 to 16-year-olds only. And in 2015, it was 1 in every 10. And in 2019, it was 1 in every 5. That study is done every 4 years, and it was in the field this year. So we await the results of that next year. I anticipate that it's probably, unfortunately, gone up again, I would imagine. So what do we do in terms of the projects that we're involved in the HSE? So we monitor the service and coordinate and report on KPIs and key performance indicators related to the service. We audit the service and the data entry on. We're lucky enough to have a national patient management system. And we're trying all the time to work with our colleagues in IT to integrate our system with other IT systems across the HSE so that we can get electronic referrals, so that our health professionals who engage with the public can ask the question about whether they smoke or not and offer them support and electronically refer them straight into us, which, you know, hopefully leads to a better outcome for them and they get proactive care from us. We manage our quit line. We're obviously involved in lots of international networks in terms of internationally discussing and talking about what they do in terms of quit lines internationally and what they do in terms of campaigns internationally and learning from others. And we've got a very exciting new service starting in January where we're going to implement incentivized quitting. So this is where we're going to provide vouchers and financial reward to people who are quitting in deprived areas. And we know from the research that really does improve quitting success by up to 50% in very deprived areas. So this is a targeted measure, and we're piloting that in 3 sites next year: in Longford, in Limerick, and in Cabrafinglas. So we're very excited to start that project. It's a HRB funded pilot. We're tendering at the moment for a new national pharmacy supply a provider who will support us to provide stop smoking medication in a more streamlined way. And we're also working on new 3rd year junior cycle vaping lessons. We have some other lessons that we produced last year and the year before, which Ed will talk about later on. This is just a map of all our clinics. They're not all on there, but so we've over 300 clinics across the country, and this just gives you a sense of the spread of all of our clinics. And we also have the national quit line. So if you want to access a service and you don't have time physically to go in and physically meet somebody, you can access the quit line service, which are open longer hours as well, so open late in the evening and on Saturdays for half a day. So in terms of treating tobacco addiction, you know, nicotine is highly addictive, and there's the behavioral and psychological attachment to smoking that many people have for lots of years. So we work on both of those things. So we work on the behavioral and psychological support, as well as stop smoking medication and combination and nicotine replacement. And we'll be talking to Susan a little bit about that later on. Lots of other supports available for people as well. We have the Quit website, and you can log on and develop a Quit plan for yourself, where you get motivational emails and text messages to support you along the way. And we'll be launching a new HSE app early next year, and there'll be a Quit plan element to that app, which we're very excited about building. We also have the Facebook page as well, where you can talk to other like-minded people who've come through that journey. In terms of, how are we doing in terms of stop smoking service? So in 2022, we got a significant investment through Sláintecare funding, and we got lots of new staff through various funding schemes. And we can see a growth in the number of people who've come to our service. Before that, we had 10,000 kind of coming to the service. But last year, we saw over 19,000 people through the Stop Smoking service, and we're on target to achieve our target this year. So at the end of October, we had seen almost 17,500 people. So, it isn't true to say that everybody who wants to quit smoking has already got access to support. When you build the service, when you provide free, remove the barriers and provide medication and free medication to people, people engage and people come to the service and get that support. So I'm going to just stop talking now and introduce a video from Tala, where we're going to hear from there's no point in you listening to me about what the Stop Smoking service is about. You're better off to listen to clients who've come through the service and hear from their own experience. So we're going to play the video from Tala, and then we're going to talk to Susan, who's a Stop Smoking advisor. Thanks very much.
I first heard about the Stop Smoking service while attending another course in Kavanagh it was called Heads Up. It was a men's group. Just something popped into my head and going, I wonder would I give that a shot, the quit smoking program.
I stayed with it really for health reasons, because I was beginning to be scared. My breathing wasn't great when I was walking, and I just didn't feel good in myself at all. Now that I have stopped, my blood pressure is gone down. My doctors are quite pleased with it, and I feel much healthier in every way. When I walk, my breathing is much better, and I just feel good in myself.
Quitting smoking has given me a new lease of life, health-wise and family-wise. I could sit through a whole conversation for the whole night, not leaving the table to go out. The benefits I feel in myself and in my body and the whole lot, it's amazing.
I continued on with it because I was getting the nicotine replacement therapy free. It suited me because I was attending Kavanagh at the time, so I could just drop in, have my weekly chat.
I really felt very comfortable, and I needed to stop smoking, and I got great support.
And when you have that support, it's great. The difference the last few months has made to me is unbelievable.
Like you do really notice it now financially. I do often say I don't know how I could afford to smoke. I couldn't now. I wouldn't even think about it now.
Nobody thought I was going to give up smoking after 40 years. They were all in complete shock. Went out, daughter was impressed. She was a sort of on-off smoker, so she quit as well. So she gave up them as well.
It's a big transition, and it takes a lot of getting used to. And not only that, it takes discipline, but it's up to yourself. At the end of the day, you have to say, what do you want?
I was able to go from the quit smoking to the healthy food made easy with my sister, and her and I really enjoyed that class. We really did. We used to look forward to coming to it every Thursday.
Every Saturday now is a healthy day for my mum, our neighbour and myself, so we go buy all the products, make it, and so we're eating healthier as well. So it's just constantly improving from one thing to another. Well, if I was to recommend it to anybody, the reason to do it would be health benefits. You're saving money, it's free, it's accessible. You speak to a person every week, so it's totally different than trying to do it on your own. You have a bit of encouragement, you have somebody to talk to, you can ring them if you need to.
I thought that, this is going to kill me because this is all I'm going to be doing, and it has really made a big difference in my life.
I'm very into swimming. Had a pool, swim in the pool every morning at 10 o'clock, and I could nearly do the length underwater. That's how good that was. I wouldn't have done that last year.
When I used to go to the course, then a very visual thing for me was the CO2 monitor. So I could blow into it and see the improvement on a weekly basis. I hadn't planned it, so it was a complete shock for me, and it was a complete shock for the whole family that day. I says, they thought I'd never give up smoking, like, and I thought I'd never give up smoking. They could see the improvements in my health. I could see the improvements in my health. I have to say, it's great.
Thanks. I think that video really tells the story from the client's point of view in terms of the journey that they go on to try and quit, and you know, the improvements across their whole life in other areas as well. And I'm delighted to be able to welcome Susan McNichols, who's a stop smoking advisor in North Dublin, Grange Gorman. And Susan meets clients like those that we've just met every day of the week. So I'm delighted to be able to introduce you, Susan, and ask you a few questions about what it's like to work as a stop smoking advisor and the kind of clients that you meet. So can you tell us a little bit about what someone might expect when they come into a service? You know, how does it happen? How do they get to you in the first place? And then what happens when they come to see you?
Sure. Good morning, Martina. Good morning, everybody. Well, the first thing to say is that the video is excellent. It really represents how delighted people are when they come into the service, because like smokers in general are, you know, very nervous about quitting. It's a big step. And they come when they're ready, or even if they're thinking about smoking, I would encourage, or quitting smoking, I'd encourage them to come in, because it really isn't, it's non-judgmental service. It's very holistic approach, and people are very welcome to come in through the door or online as often as they want. So when people feel that they're ready to come, we encourage them maybe to contact quit.ie, to look up online and see what service suits them. Because there are many different options, which is wonderful, which you've covered already. But just a brief synopsis: there is the Week on Quit service, which is provided through the local community partnerships. There's also the Quit line, and there's also the one-to-one, which is what I'm involved in, where there's advisors all over the country that are very willing and look forward to trying to assist somebody on their quit journey. So not to be scared, that's a very important point. And that it's free for everybody. It doesn't matter what their background is. It doesn't matter, you know, what age they are, and we've people of all ages, young and old, and they're all very welcome. As I said, it's non-judgmental and it's free for everybody. So whether they have a medical card or not, you know, it doesn't matter. So that's the first thing to say. So when they've made that decision and they make the call, or they go online, or whatever way they decide to access the service, they will be contacted by an advisor like myself, or from the Quit line, within a matter of days, shorter if at all possible. And it'll just be a very welcome introductory phone call to see, you know, how they are, what their background, their smoking background is, you know, where they're located, what date or time would suit them, you know, what type of service that they would like, whether it's on the phone or one-to-one support. And we would take their details and organise a pre-quit appointment. And the most important thing, I think, to tell them as well, is to reassure them that they don't have to be quit the day they come through the door. And we're not going to ask them to quit the day they come through the door. So that's all part of the journey.
They have time to get their head in the space.
Yeah, of course. Because, you know, that's scary. People think, oh, I'm not going to go until I'm absolutely ready to quit. Whereas I would discourage that. They come in and have a chat anyway. And it mightn't be as scary as you think. We hope that you'll actually find it very relaxing, because that's what it's all about.
Brilliant. And is there more than one appointment, Susan, or is it just one appointment, or how many times should you engage with somebody?
Yeah, of course. So look, some people have smoked for a long time, and you know, these things aren't done in an instant. So people might have to have a number of appointments. But as a rule, and we're very flexible on this, people come into us for a pre-quit assessment. Some people need more than one visit before they decide on a quit date. And then once they decide on a quit date and they actually quit, we will be in touch with them every week. Initially, for the first 12 weeks, they get free combination NRT. And we give them a year's behavioural support. And obviously, if they lapse or have a relapse, which they may have, they can come back and within the service as well. So we're never going to turn people away. So that's just very important for people to realise that. Yeah.
Brilliant. And so how do they access that free NRT? Through yourself, is it, or?
Yeah, exactly. So once they talk to an advisor, we do an assessment on them. It's called the Fragerstrom test, and we would see, you know, how much they smoke, how long they smoked, what you know, amount of nicotine they're taking every day. And so in order to quit, we obviously need to give them the evidence is there. It's very strong that you are twice as likely to stay off cigarettes for a year or more if you use combination NRT, and 4 times more likely to stay off cigarettes for a year or more if you use the combination NRT alongside an advisor. So obviously that really increases your chance of just rather than just using willpower alone. So we would do that assessment during the consultation, and obviously we would also ask the client what suits them. We would, usually we like to try and use a patch, which is a slow acting. And then in addition to that, we also would use a fast acting, because the research is very strong that if you use both, one of each, it really works very, very well. But of course, the client would tell their preferences, because it could be gum, it could be spray, it could be a lozenge. It all depends on what they'd like.
Yeah.
Once that's decided, then if the person is a non-medical card client, the order form is sent on to the local pharmacy near their clinic. And if they're a medical card client or they have medical conditions, with their consent, we would contact their GP, and we would recommend a certain, whatever NRT or nicotine replacement therapy, where we would recommend we just pass on to the GP, and we would obviously ask them to prescribe it and forward to the pharmacy, if they're happy to do so, of course, depending on the medical conditions.
Brilliant. Very good. And so can you tell us a little bit about some of the kind of clients, the types of clients that have come through, what's most rewarding about this work, and maybe, some of the experience that you have?
Yeah, thank you. Well, just to give you a little bit of a background, Martina, I was a nursing midwife for 30 years, and 3 years ago I joined Health and Wellbeing, Health Promotion in Dublin North City and County, and my role started off with tobacco, and I was, to be honest, a little bit scared about that, because I was thinking, does that really suit me? But I have to say I absolutely and utterly love it. I'm very, very passionate about it, and I really believe in this program. In my mind, it's making every contact counts on steroids, because you really look after the person as a whole. It's just a fantastic service, and it really works. People come into the door, and I love the meeting people face to face. It's just really, really wonderful. You meet people from all walks of life, and particularly in Grange Gorman, and then I'm also in the enhanced community care in the chronic disease hub in St. Clair's as well. I meet people from all walks of life and ages. I have students here in TU University. I have a lot of mental health facilities in my area. I have people from the addiction centre, substance and alcohol abuse, and I've also got the homeless services, a lot of homeless hostels in my area, as well as obviously the general public. So every day is different and every client is different. So I find that I really get to use a lot of my clinical skills, and it's so much more than just quitting tobacco. I mean, obviously quitting tobacco is the #1 priority, and it makes a huge difference in their lives. But with healthcare, it's so busy nowadays. Sometimes we don't get, as clinicians, to spend as much time talking to people about their general health and well-being, whereas within the tobacco service, we look after the whole person. And while we're not counsellors and we can't always solve everything, we would absolutely refer to other services or signpost other services, if it was appropriate, and if the client wished that to happen. So just some brief examples. Over the last couple of years, I've an awful lot of students come into me, as I said, that might be smoking and vaping. Some of those are vaping because of mental health issues. They have that nicotine craving, but some of them actually have eating disorders and don't want to eat, don't want to put on take calories in. So they vape because they like the strong taste, and it gets rid of that hunger, and yet gives them the nicotine hit. So that's obviously very, very concerning. Thankfully we have the capacity within the service to refer back to the GP or whatever with the client's consent, or if they need counselling or whatever. Some people just want to be listened to, so whatever's appropriate. I've had one particular gentleman sticks in my mind as well. He lost his wife 6 or 7 months before he came to me, and he was in his 80s, and he was really lost and very socially isolated. He did everything with his wife, when he came into me, he was giving up cigarettes because he needed oxygen, he had emphysema, but he didn't want to give up cigarettes. He really protested, and he was there because he had to be there. He didn't want to be there. During the course of the conversation, over a couple of visits, I asked him would he be interested in going to social prescribing, and he said he wasn't really interested in engaging in anything different, but he agreed to go anyway. And he went and he met a wonderful social prescriber, who I think he was a difficult one, and he objected to most of our suggestions.
The suggestions, okay.
She eventually got out of him that he liked to speak Irish, and she found an Irish speaking group in his area, and he actually, loved it, went to it regularly, and actually gave him a little social outlet. And that gentleman's over a year quit. And look, obviously he still misses his wife, but he's very, very happy that he's engaging again within the community, and he's found an interest again, which is wonderful.
Oh, fantastic.
Yeah, and just to mention as well, the most recent, I suppose, achievement within the service that, you know, I've engaged with a lot of people within the homeless services, but there's one gentleman in particular who quit with me 17 weeks ago, and he was homeless with an awful lot of chronic disease. He was on the housing list with Dublin City Council, and when he came in to see me, again, very disengaged, he went to see the social prescriber again in the area, and she got him involved with certain groups. But we also got in contact with social inclusion, and I got unbelievable support from them. And that gentleman was living for 6 years in a hostel accommodation with 17 people, men in the same room as him, and he was a little bit intimidated by it all. And 2 weeks ago, he moved to a new hostel, thanks to the support from social inclusion and from social prescribing and ourselves in health and wellbeing. He moved into a hostel. He now has his own room. He actually rang me on Friday evening. He has his own room for the last week and a half, first time in 6 years. So look, it's to me, the tobacco service is so much more than smoking. I truly believe it's a brilliant program, and I believe that it shows or displays all the core values of the HSE. You know, care, compassion, trust, and learning. That is what the tobacco program does.
Brilliant. Wow. Thanks very much, Susan. Really inspiring stories. And thanks very much for sharing those. So what we'll do now is we're going to move to Darina. I'm going to introduce Darina. Darina is the national campaign lead for the Quit campaign in national communications. And Darina is going to talk to us a little bit about how we develop good and award-winning stop smoking campaigns and the history of those, and how they're evaluated and all of that. Thanks very much. You're very welcome, Darina.
Thanks, Martina, and thanks, Susan, for those stories. That's one of the reasons why I really like working on this campaign. Actually, is you hear stories like that all the time, which is lovely. Yeah, so I'm the Quit campaign manager, and I work in HSE communications and public affairs. So the Quit campaign has a very clear purpose. We want people who smoke to know that quitting smoking is the single best thing that they can do for their health, and that we're on their side. So we try to get smokers to obviously quit, but more importantly, quit using our evidence-based support, and to try again and to keep trying. So the campaign lives across a variety of different channels, mainly TV and video on demand. We're also live across digital and search. So that's Google search, for example. If you type in, you want to quit smoking, you'll see one of our ads, and we drive traffic to our website. We also have radio ads, digital audio advertising as well. We're always on social media. So Facebook, Instagram, TikTok, Pinterest, etc. We have a lot of ads running there. We do a lot of news and media stories with our colleagues in the press office. We do different partnerships and collaborations. So, for example, we're sponsoring the Premier Sports 3 p.m. kickoff on the Premier League game every Saturday at the moment. So our messages appear there for the whole of the Premier League season every Saturday to our audience. And we also advertise out of home as well. So there are different posters that you might see. For example, we've posters in the Aviva Stadium washrooms, or on bus stops, or on buses and things like that. So we're very active there too. So the Quit campaign has been live for a long time. So back in 2011, the main advert was around 1 in every 2 smokers will die from a tobacco-related disease. And that evolved into a campaign that featured a man called Jerry Collins, who was actually dying from a tobacco-related disease. And that was a really powerful campaign shot with his family, where he told a story and basically his regret of how he had taken up smoking. And unfortunately, Jerry did pass away. So then on to 2017, the main message was the I Will Survive message. And that was through the Gloria Gaynor song, which I'm sure a lot of people can remember. It was a bit of an earworm. And the story around that advert was people that had overcome smoking and it hadn't beaten them, and they were able to move on with their lives. And then after that campaign, we had the last stop. So that message consisted of, if you stopped smoking for 28 days, you were 5 times more likely to quit for good. So this kind of moved into a more positive space again. And it gave people a really actionable goal to try and stop smoking for 28 days and to use our support to do that. But we always have challenges because it's a very difficult campaign that we're trying to run here. So those campaigns were really good at just decreasing the numbers of smokers in Ireland, and as well educating the population about those health risks associated with smoking, because as you can see, we spoke about those health risks and the dangers of smoking for quite a few campaigns and for a good few years as well. They also did a really good job of raising awareness about the service that the HSE offers. But we still, as I said, we experience a lot of challenges when talking to this audience because the main one is smoking is really addictive. It's really, really hard to give up, and people don't want to give up smoking. So they can avoid our messages because they don't want to hear from us. We're also in a position now where we have a lot of hard to reach groups where we're trying to get our messages out to. So that just means we have to be more strategic and do different things to kind of reach these groups. There's always a desire as well for people to go it alone, that they won't want to use our support, they won't want to use NRT, they want to go cold turkey, and the evidence shows that they're less likely to have a successful quit attempt. And that's, it's a very big challenge for us, and it will always be a challenge. There'll always be people that won't want to engage with the service like ours, which is fine, but we have to be able to help them in other ways then. Paul's going to talk about this in a bit more detail later on, but there's a big inequality gap that's formed for smokers in the past few years. So people who are on lower incomes are a lot more likely to smoke, especially people in more deprived areas as well. There's a big difference in the numbers there with people in more affluent areas. So we were in a position then where we wanted a change of direction for the campaign, which was launched in 2023. So I'm just going to speak a little bit about how we develop our campaigns, and then I'm going to show you that change of direction. So we're actually always carrying out research. So if that's testing our messages on social media or ad trackers we do twice a year, we're always talking to quitters as well and talking to people who use our service. We've got great access through the Quit line and through Stop Smoking advisors like Susan, where we can talk to people who use the service on quite a frequent basis. So this keeps us really close to the audience. We don't have a check-in once every 3 years. It happens quite frequently. So when we're developing a new campaign, we brief our agency partners with information on our target audiences, the challenges that we face, any of our successes that we've experienced over the recent years. And we talk to them as well about any external influences that might be happening around smoking. For example, how a lot of people now are smoking and vaping, which is, that wouldn't have been the case in 2011, for example. And then we also share as much research as we can that I discussed there previously. So they pitch us their ideas and strategies back, and then we assess these ideas and strategies with the TFI programme and different communications colleagues. So again, we go back to talking to our target audience to test any of those creative ideas and strategies that we think will work in terms of driving quit attempts. And then this gives us a really clear idea of the best approach that we should use when developing a new campaign. So after that, we move into filming. We record any radio ads we might have or any other creative development where we need to produce different assets to live across, the out-of-home posters I spoke about, or the digital display advertising, or anything that we'll need on social media. And then once we have everything created, let's say, we work in really close collaboration with our media agency and our social media agency, as well as different HSE teams, so that we can deliver the campaign to our target audience. And then we also, we're always measuring our results, and we've loads of ways to do that. We've got visits to the quit.ie website. quit plan sign-ups, we've calls to the quit line, people engaging with the stop smoking advisors around the country, quit rates, and then leads that are collected on social media, and then overall smoking rates across the country that Martina spoke about earlier. Yeah, so Cormac's going to show you this ad in a minute, but what we developed to launch last year, so this has been live now for nearly 2 years, is the message around taking back control. So we moved away from the idea around the health risks with smoking, because the audience knows about that and they're still smoking. So we wanted to move into more around the psychological control that smoking has over people. People are kind of, there's a lot of benefits that people have associated with smoking, well, perceived benefits in terms of it helps them socialize, it can relieve stress, things like that. And we wanted to tell the audience that that's actually not the case, that smoking's in control of you. So I'm going to, well, Cormac's going to play that ad for you now, so hopefully that works.
Once you quit smoking, you realise it's not the friend you thought it was. Quit for 28 days and start taking back control. Find out how at quit.ie.
Thanks, Cormac. I'm just going to share my slides again here. Great. Yeah, so you can see that's we're not talking about the health risks at all, and we've still kept that 28 days in that message as well, because, as I said, that research where we're always talking to quitters and smokers, people really liked the 28 days goal, and that came through for 3 years of feedback basically. So we knew that it was really important not to drop that. It still had a lot of weight, a lot of value. So we were able to keep that in the new campaign, which we were very happy with, and we've gotten a lot of feedback about, the good in that. And then I just wanted to talk about as well the free nicotine replacement therapies that were also launched in 2023. So this was new news for the campaign, and a bit of a curveball as well to add in, because we'd obviously launched our main campaign, but then it was Martina, etc., were able to launch free NRT, which was really good. But we knew that there was a bit of an information gap around NRT, because it's never been something that we would have particularly profiled in terms of the campaign. So we had a need for new assets and more information. So we did a photo shoot last year of some NRT products because we wanted to be able to own our own photography and not to use stock imagery. And this is kind of a challenge that communications people have all the time. We hate using stock imagery. So we held a nice photo shoot that we were able to then use these assets across a variety of different things. So this, for example, is an out-of-home poster that we developed with our creative agency. And you can see here that the actual product, so the patch or the gum or the lozenge, is covering up the negative, and it's giving a positive message, and also getting across that NRT can help you quit and hopefully drive traffic to the website. So we were able to use these assets across a number of different things, like on social media and different stings and posters as well, and videos, etc. So that's really handy for us to have in our locker. We also developed a new quit booklet, because we needed to give more information around NRT, and we wanted to refresh away from the kind of doom and gloom health messages that we'd been kind of so consistent with over the last few years. So we gave it a new look and feel, and that was recently launched in the Quit Kit, I think last month. So that was a great thing to develop with regards to the new information about the NRT. We also shot new videos with a couple of stop smoking advisors in August this year. And we went into a variety of topics that we know come up time and again for people, in terms of how to use the gum properly or the patch, how long they should use the patch for. And there's often kind of different questions around what happens if I relapse when I'm on NRT, or am I replacing the one addiction with the other? We know that that's, you know, can be a question for people. So we developed a few videos to try and address some of those needs. And Cormac's going to play the video here on how to use the NRT gum.
If you smoke, nicotine gum can help you quit. It comes in a range of flavours and gives you a quick hit of nicotine after chewing. Here's how to use it. Each hour, choose one piece of gum. You can chew up to 15 pieces of gum a day. It gives a quick hit of nicotine and helps keep the cravings at bay. Chew the gum slowly until the taste becomes strong, then rest the gum between your jaw and your cheek. This is called the chew and park technique. It allows the nicotine to be absorbed by your mouth's lining. Once the taste fades, you can repeat 2 or 3 times for 30 minutes. Chew until strong again and rest between the jaw and cheek.
Thanks, Cormac. Yeah, so those videos will be shared across social media. They'll be on the quit.ie website, and they'll also be sent out to people as links. So if the Stop Smoking Advisor, for example, knows that their client might be using the gum and the patch, they can just give them the links specifically for the gum and the patch. They don't need to look at, you know, the lozenge, because they're not using the lozenge. So that's it for me. I'm going to hand you over to Dr. Paul Kavanagh, and he's the Public Health Medical Advisor to the TFI programme. Thank you.
That's great. Thanks very much, Darina. So I'm just going to share my screen. Okay. Great. So pleased to be with everybody this morning to speak to you specifically around the implementation of free nicotine replacement therapy, and to answer the question, did that help us improve our stop smoking services? So I'm presenting some work that I did with my colleagues Aisling Sheridan and Peter Nocton, and also colleagues across the HSE Tobacco Free Ireland team. So I'm just going to zoom out to begin with and reiterate some of the messages that Martina opened with, just to give us that picture in terms of where we are at the moment around tackling the harm caused by smoking across the population. So, you know, on the positive side, we have had strong political leadership, which has meant that we've seen the implementation of a number of high impact strategic policy interventions, including, for example, the workplace smoking ban, the implementation of plain packaging, all of which have helped to reduce the harm caused by smoking across the population. We've seen those policy interventions then translate into reducing smoking prevalence. And, you know, as a country then, buoyed up by the success that we've had around tackling the harm caused by smoking across the population, in our most recent policy document, Tobacco Free Ireland, we set ourselves a tobacco endgame goal. And that means trying to eliminate the harm caused by smoking across the population and trying to reduce smoking prevalence to minimal levels, or 5% or less. And the target that we set for that is 2025, which is next year. So lots of good news, lots of good progress in terms of tackling the harm caused by smoking across the population. But of course, we know that our work is not done. As Martina said out at the start of the webinar, we are still deep in a continuing epidemic of smoking-related harm here in Ireland. And in terms of putting a number on that, in an average week, there are almost 100 deaths that are caused by smoking. So that's 100 families who are experiencing bereavement because of avoidable mortality that's been caused by smoking. And each week there is a minimum of 1,000 hospitalizations that are caused by smoking, and that's an underestimate. That's the actual figure is likely to be higher than that. And I suppose that's a timely reminder for us, particularly as we move now into winter and the sort of seasonal pressures that we see in our health services, that in terms of protecting our health services, ensuring our health services are sustainable, you know, there's a very high burden of smoking-related harm across our hospital services, across our community services as well. And that's really a mandate for our action across the health services in terms of trying to tackle smoking as a clinical care issue. In terms of the different risk factors that impact population health, we know that in Ireland, smoking does remain the single leading preventable cause of ill health, disability, premature mortality, above and beyond other factors that we may discuss, which are also important in terms of issues like obesity, in terms of issues like alcohol, in terms of issues like air pollution, but proportionally, smoking still remains the leading preventable cause of ill health. While we've seen good progress in terms of reducing smoking prevalence across our population, that progress appears to have stalled in recent years. And we're certainly off target in terms of achieving that very legitimate, very valid goal of trying to build a tobacco-free Ireland by 2025. So it's unlikely that we're going to deliver that. And certainly we're engaged with our Department of Health in terms of the need for a stock take and refocus in terms of that very legitimate goal. Now, as Martina and as Darina called out in their presentations, one of the things that we have been doing, in addition to tracking the overall trends in smoking at a population level and the overall harm that's caused to the population due to smoking, we have an increasing focus on the distribution of smoking and the differences in smoking and smoking-related harm that there are across different population groups. And that's very much kind of brings us to this idea of leaving nobody behind as being a big theme for us within the HSE Tobacco-Free Ireland programme. So just to put some perspective on this, we know, sadly, in Ireland, that there's a wide difference in people's experience of health across socioeconomic groups. So we know for men that there's approximately a 5-year difference in life expectancy, depending on whether you're in a higher versus a lower socioeconomic group in Ireland. And then for women, we know that that difference in life expectancy across socioeconomic groups is around 4.5 years. And when we look at international studies, they would indicate to us that about half, 50% of that difference, that gap in health expectancy that there is for men and women in Ireland is explained or is due to differences in smoking and differences in the experience of smoking-related harm across socioeconomic groups. So I suppose this would really mean that if we want to, as we all do, make progress in terms of trying to achieve health equity, trying to address those unfair differences that there are in health across the population, then we really do need to include in our discussion a focus on tackling the harm that's caused by smoking. This slide, this picture on the right is some up-to-date analysis that we recently published from the HSE Tobacco-Free Ireland programme in conjunction with some colleagues from the Royal College of Surgeons in Ireland. And in this study, we took Healthy Ireland data, that's the annual snapshot of population health that is conducted by our Department of Health, and those annual reports are published. And then we looked at smoking prevalence, and we looked at it across socioeconomic groups, in this case indexed by the education level and the area-based deprivation that was associated with different respondents. And what we found is across time, if we look at the start of the period for the study, which was 2015, there was just over a 2-fold difference in smoking prevalence across socioeconomic groups here in Ireland. And when we extended the study and we looked at it year on year, bringing us up to the most recent year of the study in 2022, what we found is that not only did that difference in smoking prevalence across socioeconomic groups persist, but actually what's quite worrying and quite a cause for concern and quite a focus for us all is the fact that that gap in smoking prevalence has actually widened across time. So from the period 2015 to 2022, that gap went from being just over a 2-fold difference to over a 3-fold difference in smoking prevalence across socioeconomic groups here in Ireland. So in summary, there's a very wide difference in smoking prevalence across socioeconomic groups in Ireland. Over time, over recent years, not only is that gap persisting, but actually it's widening. And that gap or that difference in smoking prevalence across socioeconomic groups is a very significant driver, drives over 50% of the difference in health outcomes that is experienced by people across socioeconomic groups here in Ireland. So in summary, as Martina called out and as Darina reminded us, really, if we are concerned about addressing health inequalities, which of course we all are, then really we need to have differences in smoking at the centre of our discussion in terms of health inequalities. And you know, in terms of why that gap exists and why that gap may be widening, we're all aware of what we call the wider determinants of health, or the social determinants of health. And this is the idea that the environment in which people live their lives, the physical, economic, cultural, social, political environment, you know, that is what shapes our health. And depending on people's socioeconomic position, they can have a very different experience of the social determinants of health. And on the slide here, I'm referencing some good work that was done by colleagues in Scotland. And what they found was that depending on the socioeconomic position of the neighbourhood in which people live their lives, their exposure to tobacco retail was quite different, and people who lived in more disadvantaged neighbourhoods were more likely to be exposed to tobacco retail. So that's one of the factors that may be driving this gap in smoking, this difference in smoking that we observe across socioeconomic groups in Ireland. So differences in the experience of these wider determinants of health. In terms of quit success, this is something that we've been tracking through our state of tobacco control reports. And again, what we would observe is that for people who, through the Healthy Ireland survey, report that they have made a quit attempt in the last year, the reports of being successful is more common among people who are in higher socioeconomic groups. So there's differences in quit behaviour and quit success depending on people's socioeconomic position. And I suppose one thing that we need to be very conscious of is when it comes to the big policy measures that we're implementing, like, for example, plain packaging, that we're tracking those very carefully and trying to understand whether, in fact, they are benefiting everybody across the population equally, or whether perhaps there's a different experience of those big strategic policy interventions for people depending on their socioeconomic position. And this, on the slide here, I'm referencing a piece of work that we did looking at the implementation of plain packaging. And actually, on a positive note, we didn't identify that there was any significant evidence that there was a difference in the experience of the benefit from the implementation of plain packaging here in Ireland, depending on people's socioeconomic position. So we have a big challenge in terms of not just wide, but widening differences in smoking across socioeconomic groups here in Ireland. So that's really a mandate for action for us, those of us that work in the area of tobacco control and trying to bring the harm caused by smoking to an end through tobacco endgame. So this issue of differences in smoking, health inequalities related to smoking, is something that we looked at in the development of our national stop smoking guidelines. There is a good evidence base around what works in this area, and specifically 2 interventions are called out as being particularly effective in terms of not just reducing smoking prevalence for everybody, but being pro-equity. In other words, having the greatest impact for those who are furthest behind, those people that are in lower socioeconomic groups. And those interventions would be taxation policy. So that's the year-on-year price increase that we always advocate for as part of our budget in terms of the price paid by people for tobacco products. But also, and I think this is important for those of us that work in the area of designing and providing stop smoking services, we know that if you target and tailor stop smoking services with communities who live in more disadvantaged areas, actually you can make those services more effective for those people. And there's great examples of good work across Ireland in that area. So, for example, the We Can Quit initiative will be a very good example of trying to target and tailor services to make sure that they are more effective for people who live in more disadvantaged communities. So specifically then within the guidelines, one thing that we looked at was the idea of whether or not we could mobilize fiscal measures as a way of trying to make services, stop smoking services, more effective, more targeted and tailored for people who live in more disadvantaged communities. So by fiscal measures, what we mean there is the sort of out-of-pocket expense that people may experience when they're using stop smoking services. And there's a very strong rationale for this grounded in evidence. So on the right-hand side here of the slide here, I'm cross-referencing a very big report from the Cochrane Library, which is a synthesis of a number of different studies, which looked at how you design the financing arrangements within health systems to try and make stop smoking services more effective. And what those studies found was that when you eliminate the cost that people face in terms of accessing stop smoking services, that you can actually up to double the effectiveness of those services. So definitely there's very strong evidence that if we look at the out-of-pocket expenses that people face when they access stop smoking services, and if we reduce those out-of-pocket expenses or try ultimately to eliminate them, we can actually increase the effectiveness of services. So that's one way that we may be able to target and tailor stop smoking services and make them even more effective, particularly for people who experience disadvantage. So we took that forward, and as we know, people within our country, they can access face-to-face behavioural support for free across the country. And then when it comes to augmenting that behavioural support with stop smoking medicines for people who have a general medical card, and that would be about a third of the population, we know that they can access those medicines not quite for free, but almost for free. They pay pretty minimal kind of out-of-pocket expenses around that. But we know then that there's about 2/3 or almost 70% of the population who still face out-of-pocket expenses when it comes to accessing stop smoking medicines. And for those people, those out-of-pocket expenses could be a disincentive or a barrier for them accessing effective support in the way of using nicotine replacement therapy. So we put in place an initiative. We initially piloted it back in 2022, and then in 2023, we mainstreamed, and as you can see here on the slides, at a national and at a regional level, we started to promote the fact that our services were providing access to free NRT for everybody. So not just for people who traditionally had that free access through having a GMS card, but also for other people as well. So we conducted an evaluation of that. We used data from Quick Manager. Within that, then we had around data for around 20,000 service users, and we focused in just on changes experienced for those people who weren't recorded as being in receipt of a GMS card, because of course it's those people who are not in receipt of a GMS card for whom this intervention was particularly kind of relevant. And we segmented those service users into those who used the service before this intervention, making an NRT available for free. And that was between January 21 and February 23. And then those people that used the service afterwards, and that was from March 23 onwards. And we closed the study then at the end of 2023. And we looked at indicators of process of care, which is NRT use, and then the outcome of care, which was the quit rates. And we looked at those at 4 weeks and then again at 12 weeks. So what did we find? Firstly, in terms of using NRT as part of a stop smoking attempt, what we found was following implementation of free NRT, the proportion of service users using NRT increased from 40% to 60%. So that's almost a 50% increase in the proportion of service users that were using NRT. So that's a great result. And then in terms of what that translated to in terms of quit success, at 4 weeks, the proportion of service users that were reporting that they were smoke-free rose from just under 30% to just over 40%. So that was a 33% increase in 4-week quit status. And then when we looked at the quit status at 12 months and we compared people who used the service before free NRT and then those who used it after free NRT, what we found was at 12 weeks, there was a 50% increase in the proportion of people that were smoke-free. So, I mean, these are fantastic results. You know, kind of in my own work, I spend a lot of time looking at data and trying to find different effects. And to see effects of this scale, like a 50% increase in people that were using NRT, a 50% increase in people that were smoke-free at 12 weeks. These are phenomenally powerful findings. We did some further detailed analysis around it, where we used more advanced analytic methods, and we kind of controlled out other kind of factors that may have been potentially kind of confusing what we're seeing at that overall aggregate level. And what we found was when we used those more advanced analytic techniques, actually what we found was that people who used the service after the implementation of free NRT were over 3 times more likely to use NRT than people who used the service beforehand. So that's a phenomenal step up in terms of the use of free NRT. And then we did a little bit of work then to understand quit success, and we looked at a range of different factors within that part of our analysis. And what we found was that people who used the NRT compared to people who did not use the NRT were 1.7 or almost 2 times more likely to be quit at 12 weeks. So that's supporting the rationale of what we've done here in terms of enabling people to have better access to a highly effective support to enable them to stop smoking in terms of using NRT. So this data here on the right-hand side of the slide is supporting the effectiveness of NRT. And the other thing that we found was when we looked at the data, what we found was that being in that part of the study, the more recent part of the study where NRT was available, that in and of itself was significantly associated with being successful in terms of your quit attempt at 12 weeks. So there was about a 20% increase in the likelihood of somebody being smoke-free at 12 weeks when they were in that period in the study when they were eligible for free NRT. And I think what that's speaking to is, as we all know, and I know a number of you on the call here are delivering these services on the ground on a daily basis, and you will know the work that you've done and that we have done with you to improve the effectiveness of services, to improve training, roll out a quit manager, and various other interventions. And what this is showing us is sort of a trend in terms of increasing service effectiveness as a consequence of all of those improvement measures over time. A couple of things that we found that I'll just note here as being points for us to watch. What we found was that the uptake of free NRT was greater among men than among women. So I think there's something there for us to keep an eye on over time. And we also found that it was greater among those that had higher education levels. So again, the idea in terms of making NRT available for free is that it's about lifting the boats for everybody, trying to make the service more effective for everybody, but particularly trying to address some of those issues for people in lower socioeconomic groups, particularly those people that are just at that threshold where they maybe don't have a medical card, but still experience disadvantage and will benefit from this. But there's probably something there for us to watch in terms of how we're delivering this service to make sure that it is being particularly effective where we want it to be for those people that are left furthest behind. And the other thing, and I know Prof. Smyth is going to speak about cannabis use as well, but the other thing that we found in terms of looking at quit success is that people who used cannabis or were recorded as using cannabis within the quit managers system, they were less likely to achieve a quit status at 12 weeks. So I know Prof. Smyth will speak about this further, and this is an area that we're quite interested in exploring further within our data. And then this is just showing you then, what we can see here is increased footfall through our services over time. We think largely attributable to the fact that we've been heavily promoting the availability of free NRT, and that's making the services very attractive for people. And the other thing then that we're seeing is that the over time at an overall aggregate level, the percentage of people using NRT has increased year on year, which is very positive. So look, in terms of final takeaway messages from this part of the webinar, look, just really want to remind people, and I know, as I say, a lot of you on the call are involved in the delivery of stop smoking care on a day-to-day basis, but really, I do think we need to sing out loudly across the HSE that stop smoking care is life-saving care. I mean, if people close their eyes and think about the health services and the dramatic impact that it can have on life, you maybe think about ambulances coming in to emergency departments, you think about, operating theatres and people having scans, but really, the delivery of really good, which is what we are delivering, really good stop smoking care, that is a life-saving part of our health service because it absolutely radically changes the odds for people who smoke in terms of their health experience. Stop smoking care is key to reducing health inequalities. I mean, we are always engaged in health and well-being and public health, want to improve health for everybody, particularly for those people that are furthest behind. And I think what this presentation is emphasizing is that stop smoking care is a key in terms of addressing health inequalities. The implementation of free NRT worked, and in fact, I would say it was a runaway success within the services here in Ireland. So much so, as Martina will tell you, that we've kind of been playing catch up in terms of making sure that we have budget provision to meet the demand around all of this, which is a good position to be in. And I think as well what the work here that I've presented illustrates is a lot of hard work gone in on the ground in terms of implementation of Quit Manager as a electronic patient record around people using stop smoking services. A lot of work I know by my colleague Aisling in terms of the design delivery of Quit Manager, and then we would know as well that with Elaine, a lot of work in terms of training and helping people use that system. But I think, you know, we now have a really great platform that will enable us to monitor, evaluate and quality improve our stop smoking services on an ongoing basis. So I'll leave it there, and happy to take any questions at the end.
Thanks a million, Paul. I'm just going to share my screen and I'm going to speak a little bit about e-cigarettes and vaping. My name is Edward Murphy. I'm one of the project managers on the Tobacco Free Ireland programme. I'll just share this up. So I'm just going to give us a whistle-stop tour through all things e-cigarettes and vaping. We'll take a look at the products. We'll take a look at the HSE's current stance in the products and things like that. And then we'll have Professor Bobby Smyth join us to talk about some novel synthetic HHC products in cannabis and things like that after as well. So what are e-cigarettes? Well, I suppose essentially they're nicotine delivery systems, and they're designed to do the same thing that a conventional tobacco cigarette does, and that is to deliver nicotine to the human body, to get it to the bloodstream, to get it to the brain, to be able to feel the effects then of that nicotine in the body. E-cigarettes would have started out a decade or 15 years ago looking rather like the one on the left over here. They were like, you know, hard plastic cigarettes with a little light on the bottom, and you might remember seeing these in petrol stations and places like that. And they weren't particularly good at delivering nicotine, nowhere near the same sort of nicotine delivery that a tobacco cigarette would have. But they evolved very quickly over time to look more like these tank style ones. And in the last 2 or 3 years now, you'll be more familiar with the disposable type e-cigarettes that have become very, very popular in Ireland. Probably made popular by this one here. The one that looks like a long USB key. That's a dual e-cigarette. It was one of the first pod mod type e-cigarettes and one of the first e-cigarettes to use nicotine salt formulations, which are much better at delivering nicotine to the body in a more effective way that was similar to a conventional tobacco cigarette. So these are the products and what's in them. So I suppose even calling it vaping, as we refer to in our parlance, is a little bit disingenuous because it's not a vapor, it's an aerosol, which implies that it has small particulate matter. So you will find volatile organic compounds. These are gases that are emitted when the e-liquid is heated. Chemicals like benzene and xylene, they've all been found in e-cigarette aerosol. Some heavy metals such as nickel, tin and lead, flavorings that can be linked to lung disease, chemicals that have been identified as carcinogenic, ultrafine particles, so small particles that you're inhaling deep down into the lungs. A logical mind would immediately bring you to a space where, you know, that's probably not a good thing to do. And then, of course, nicotine, the chemical that makes these products addictive. So there's a list of chemicals that are going to pop up on the screen here. And according to the Food and Drug Administration in the United States, all of these chemicals have been found in e-cigarette aerosol at one point or another. The ones that light up in orange here have been determined by the FDA to be harmful to human health. So, you know, despite the claims that are often made by the e-cigarette industry that these are harmless products, the cocktail of chemicals that is present in the aerosol, you know, tends to point otherwise. And who's using e-cigarettes in Ireland? Martina has been through this in her presentation at the top of the webinar, but we know that 8% of adults, or 1 in 12, using e-cigarettes in 2016, and we've seen that grow, or in 2023, I should say, we've seen that grow since 2016, highest use in the under 25s. But, you know, the thing that's concerning us is the increase in young people. So in 2022, almost 1 in 8 of 12 to 17-year-olds said that they were using the e-cigarettes that's used in the last 30 days. And in 2019, according to the SBAD study that Martina referenced, 1 in 5 16-year-olds were current users of e-cigarettes, and 1 in 10, that's in 2015. And anecdotally, teenagers will tell you that that's probably too low, that what they see going on around them in their peer groups in reality is actually likely to be much, much higher. When the HSE were working on formulating clinical guidelines, the Stop Smoking clinical guidelines that Dr. Kavanagh would have referenced in his presentation, we did look at e-cigarettes as a, a potential tool for smoking cessation. But in order to do that, we needed, some evidence of potential harms from e-cigarettes and things like that. So the Health Research Board did a literature review in 2020, commissioned by the Department of Health. And what they found was definite evidence of early harm from e-cigarettes. So I suppose, look, nicotine dependence is the first thing to note. These are devices that are primarily designed to deliver nicotine to the human body. And when someone tries to stop taking nicotine into the body, then there is going to be withdrawal. So there's going to be irritability, frustration, anxiety. And we'd be concerned about young people using them as well in terms of taking a lot of nicotine into the body quickly, that it can cause nausea, increased blood pressure, rapid pulse, headaches, things like that, all things that are very undesirable. The Health Research Board also found that there was early evidence of harm to the heart and circulatory system, early evidence of harm to the lungs, some carcinogenic chemicals identified, and then more rare and unusual things like injuries and poisoning. So these are blast injuries where batteries do explode and injure people, and poisonings where e-liquid is consumed orally or something like that into the body. Rarer, but do happen, and of course quite serious as well. The Health Research Board also looked at whether there was a gateway effect for young people who used e-cigarettes to using conventional tobacco. And what they found was the young people who were using e-cigarettes were 3 to 5 times more likely to start smoking than a young person who never used an e-cigarette. So we were concerned about that gateway effect to conventional tobacco and the renormalization of tobacco use in Ireland as well. So the HSE stance on e-cigarettes to quit smoking, and these are the things that we would have considered when we were formulating the clinical guidelines. So does it work? And I've seen various comments in the chat about the Cochrane review of e-cigarettes versus the Health Research Board literature review and things like that. A comment on the Cochrane review that kind of leaned more towards e-cigarettes than NRT would be that it did lean very, very heavily on one particular paper. And the author of that paper was also a co-author on the Cochrane review. You can maybe claim a little bit of conflict of interest there, but the methodology would be different. And also the evidence base for e-cigarettes is just very, very young at the moment. There's not a huge amount of data there to land on a place where we can make a really, really accurate decision as to whether it's better than NRT or not. And I suppose the most important question then is safety. And there's no long-term evidence around the safety of e-cigarettes. We do have evidence of short-term harm from e-cigarettes, but there's no long-term safety data. So exercising precautionary principle would be that we would recommend people to use safe evidence-based supports like nicotine replacement therapy and other drugs like varenicline and bupropion that are routinely prescribed for smoking cessation. And of course then wider considerations. So we were concerned about normalizing youth uptake of e-cigarettes and then that transition from e-cigarettes to conventional tobacco. So in the clinical guidelines, the HSE does not recommend e-cigarettes as a tool to quit smoking. We recommend that people use our behavioural support in combination with nicotine replacement therapy. It's worth looking at some old school tobacco advertising and then looking at some of the e-cigarette advertising as well to kind of draw some comparisons between them. This is an ad from 1892 for Ogden's tobacco. And you can see here that there's a line, smoke passed through a hollow ball containing cholera bacilli had a fatal effect upon germ life. So there's a claim being made here that the cigarette smoke killed bacteria, and it possibly did. But it's kind of trying to make a health claim at the same time as well, that tobacco smoking is harmless. Of course, we know it's not. And of course, while the smoke maybe did kill the cholera bacilli, it was killing the user as well. You'll see a more ad here this is from 1919. And this is, the use of characters that appeal to children and young people. So you could argue that maybe using Santa Claus up front and center on an advertisement you know, well, they say it's supposed to appeal to adults, you know, maybe not. And you see the striking similarity here between that cigarette ad and this is a vaping ad for a company called Vapor Shark. This is an ad from the 1930s where the physician's voice was used to advertise cigarettes. So you can see here there's a claim, your throat protecting against irritation, against cough, for Lucky Strike cigarettes. It's worth noting this is 20 years before Richard Dole and the British doctors study, you know, came forward with conclusive evidence that smoking was causing lung cancer. But it makes the point that we can be quite ignorant when we're making claims about the potential harms or lack of harms of a product. And we did this with cigarettes. We did make this mistake with cigarettes. You'll see the striking similarity here between an old Kent's ad and a new ad for vaping. And then Juul brought the advertising forward into the social media age. So the use of, you know, attractive young people to advertise the product on social kind of harkens back to some of this old style tobacco advertising as well. These type of ads, and then compared to the older cigarette ad. E-cigarette products are often placed, you know, as almost health adjacent items. They're advertised as being, you know, fruity, healthy. They often look like this. They often are, you know, look like health consumer items. They're portrayed like sweets to appeal to children. And these are the most popular products on the Irish market at the moment. And again, you can see the marketing is there to be cool, fresh, and healthy. So I'd like you, the audience of the webinar today, to next time you hear an industry claim that these products are not targeted at children, so just remember some of the imagery that you've seen on the webinar here today. The HSE is doing a lot of work in the vaping space at the moment. So we have put out a leaflet for parents, guardians, and indeed young people, containing some of the most up-to-date information on e-cigarettes and vaping. We have done some information and guidance on e-cigarettes for schools, and we've developed SPHE lessons for first year and second year that has tobacco and e-cigarette content, and it leans heavily into the marketing space around empowering the young person to realize that they're a target of this particularly malicious marketing. And then we have a prevention toolkit for out of school settings as well. In terms of the legislative arena and what's been going on with e-cigarettes and nicotine inhaling products, the nicotine and tobacco, or the tobacco products and nicotine, the act that was passed just before last Christmas did make it illegal to sell tobacco and nicotine inhaling products to under 18s, and it prohibits sales at children's events, and it prohibits advertising in certain places. So you're not allowed to advertise in or at a school or within 200 meters of the school perimeter, or at places like a train or a bus station or in a cinema. It's a little bit flawed in that advertising the legislation means to advertise by the display of posters, billboards, placards, or other signage, but does not include an advertisement on or attached to a premises where nicotine inhaling products are manufactured or sold by wholesale or retail. So there's nothing in there that says that a vape shop that happens to be 100 meters from a school can't display posters and things in their windows. So we do need stronger legislation around e-cigarettes. What the legislation doesn't do is it doesn't control the content of e-cigarettes in terms of flavors. It doesn't control packaging and naming or control point of sale display. But the government has done a consultation with the public back before Christmas on the appetite for future legislation on e-cigarettes, looking at things like flavor restriction, flavor bans, controlling point of sale display. Very well responded to consultation. There were 16,000 odd responses. Interestingly, 90% of the respondents identified as being people who used vaping products. So there is evidence of industry rallying the troops to respond to the consultation, if you will. But there is some promising stuff in there around that. There's certainly an appetite for doing something around packaging and controlling point of sale display. But I'm sure we will see that progress over the medium term anyway in the next few years. I think it's probably good if we show you one of the videos now from our SPHE lessons. So this is a video on nicotine addiction.
Sometimes people who smoke or vape will say that they are not addicted and that they could quit at any time. But then they don't, despite the fact that they know that what they are doing is harmful to their health. The addictive effects of smoking and vaping are initially hidden and lead a person to believe that they are in control, when in fact they are addicted. Tobacco companies spend billions on convincing young people that smoking and vaping is somehow okay, even glamorous. For instance, they pay celebrities and influencers to promote their products on social media and pay production companies to place their products in films and on TV, all to get young people addicted and increase their profits. Nicotine is the psychoactive drug responsible for the addictive effects of tobacco and e-cigarette products. Even smoking a small number of cigarettes or just a short time spent experimenting with e-cigarettes can cause a person to become addicted. Once in the body, nicotine is fast and sneaky. It races into the lungs when you smoke or vape. From the lungs, it enters the blood and reaches the brain within seconds of that first puff. Nicotine affects a pathway in the brain called the reward pathway. The reward pathway is the area of the brain which makes us feel good every time we eat something that tastes nice or do something that we enjoy. Once nicotine arrives at this area of the brain, it attaches itself to receptors like a key fitting in a lock. This activates the reward pathway. When the pathway is activated, a chemical called dopamine is released. Dopamine is the feel-good hormone and creates feelings of pleasure. Repeated stimulation of the reward pathway with nicotine results in a rewiring of the reward pathway as your brain becomes convinced that it needs nicotine to release dopamine to make you feel good. Every time you smoke or vape, you get that feeling of reward, so you do it again and again. Over time, the body becomes convinced that it needs nicotine to feel good, but it can never get enough. Nicotine can trigger brain changes that make people, particularly young people, crave more nicotine. Until about age 25, the brain is still developing, and using nicotine can harm the parts of the brain that control attention, learning, mood, and impulse control. Nicotine also has physical effects on the body. People who smoke or vape may experience any combination of nausea, vomiting, diarrhea, cold clammy skin, a rapid pulse, dizziness, fainting. The longer you smoke or vape, the stronger the cravings for nicotine become. When you quit smoking or vaping, the reward pathway is not stimulated by nicotine anymore, resulting in less dopamine. With less dopamine, people get withdrawal symptoms. Common symptoms of nicotine withdrawal include anger, frustration, and irritability, difficulty concentrating and studying, restlessness and anxiety, difficulty sleeping, depression, hunger or increased appetite. The good news is that these changes in the brain start returning to normal the longer you go without nicotine. Getting past the first stages of withdrawal when you quit can be hard, but over time your brain rewires itself again. It stops craving nicotine and goes back to the way it was before you smoked or vaped. It is normal for young people to want to experiment as they grow into adulthood, but nicotine addiction happens very quickly, and the risk of long-term addiction is very high. There is no upside to smoking or using e-cigarettes at all. The HSE has services that can help you to stop smoking or vaping.
Thanks a million, guys. We have Professor Bobby Smyth joining us now. So Professor Smyth is a consultant child and adolescent psychiatrist and works in addiction services for young people. So Professor Smyth, you've probably heard me speak about e-cigarettes for the last 10 or 15 minutes there, and I'm sharing a slide on the screen that I think you can probably see, which looks a bit like an e-cigarette, but it's not. It's a different type of product. but also sold by vape shops. Can you maybe tell us what this is, please?
Yeah, this is a HHC vape, sort of product that seems to be widely available across Ireland, that's been sold to, I suppose, anyone and everyone at this point in time. HHC is a chemical which actually exists in tiny quantities in cannabis under natural circumstances, but the HHC in this particular vape will have been produced via sort of chemical modification of one of the other chemicals in the cannabis plant to produce the HHC. And its effects appear to be very, very similar to those that we see with people who smoke cannabis itself. As you mentioned, I work in the adolescent addiction services, and HHC is now, I suppose, present in maybe about 20% of referrals we're getting to those services. And it's also cropping up with increasing frequency to my colleagues who work in mental health services, because it seems to be causing the same mental health problems that we see with cannabis, which can in extreme cases result in psychosis.
How is it different from traditional cannabis? I've heard anecdotally that these devices that are being bought in vape shops, that it's quite strong.
It does seem to vary from person to person. I suppose one of the problems in trying to assess, how strong it is that the products probably vary in the dose of HHC per puff from one product to another. Certainly for some people, though, they report significant psychoactive effects. We also have reports of young people collapsing, which isn't something I would have encountered really with cannabis. So it's definitely a real worry, and it's been pretty shocking for me actually to realize this has been sold legally with impunity for over a year. Psychiatrists have been raising concerns about it for at least that time frame, but there's no evidence of its sale ending. And I think the number of products, other products are already, I think, on the shelves that seem quite similar.
Products that might circumvent future legislation on HHC, Professor Smyth, is it?
Yeah, HHC has been banned, I think, in at least half the countries in Europe. I don't understand why it's not banned in Ireland. But the industry is always going to be one step ahead of legislators, and they already, I think, have other products that have names sort of a little bit like THC, THCB, and THCBD or something. We do have legislation in Ireland, actually, the Psychoactive Substances Act, which is meant to make it a criminal offence to sell any psychoactive drug. For reasons, again, I don't understand. There's been a reluctance to use that legislation for these products, which are damaging the health of young people in Ireland at the moment.
And what kind of trends among young people are you seeing using these products? Just to my eye, it looks like the type of product that's marketed maybe at young men. Would that be the kind of user base that you're meeting?
Yeah, I suppose cannabis-related products are definitely a bit more common in males than females. I can't give you any data with these sorts of products. A worry I would have actually is that it's going to draw in a different market into use of cannabis-type products, which have traditionally been young men. We know with vaping and trends regarding cigarettes that females are at least as frequent as males. So I would suspect that's what we'll see here. And I suppose the worry is that these products have emerged against the backdrop of the complete normalization of vaping. Many young people probably don't even realize what's in these products when they're using them or when they're buying them. They're just sold in the exact same way nicotine vapes are sold. And for young people who've enjoyed their introduction to nicotine vaping, they're now, I suppose, diversifying the chemicals that they're consuming via vaping, which has become so normalized.
So it could be the case that a young person is out socializing. What they think they're taking a couple of drags from is a nicotine containing vape, and is actually HHC containing vape, and then they're having effects that they didn't anticipate or perhaps want.
Potentially, but I also think it's probably the case, even if it is explained to them that this is something different, this is HHC, the fact that they've maybe previous experience of nicotine vapes facilitates that step. I suppose a stepping stone effect or a gateway type effect is, I think, what we can anticipate.
And I guess it's probably a very much a buyer beware market with these products. If there's no legislation and regulation, you can't be sure that what's written on the packet ingredient wise is what's actually included in the device.
Yeah, I mean, there's zero regulation of this market. At least there is actually some regulation of nicotine vaping. It is entirely, there's no law saying you can't sell these to 12 and 14-year-olds, and they are being sold to 12 and 14-year-olds. Some of the shops will sort of say they have an ethical standard themselves where they won't sell to under 18s. But even if you go to the websites, you just click on the website and say, "Are you over 18?" You know, that's as sophisticated as it is. And you have your mammy's credit card, just pump it in, and you'll get HHC posted out to you. It's a worrying direction to travel, I guess, for us to be in.
That's definitely worth noting that I mentioned when I was speaking that it's now illegal to sell a nicotine containing vape to someone who's under 18, but these are not nicotine containing products. They look like a nicotine containing product, but they're not that. Therefore, they don't fall under that legislation. So we're kind of operating in a real grey area at the moment.
Yeah, and I guess one of the concerns is that I think, you know, when we live in Europe, it's a pretty regulated society. There's an assumption that's what's sold in shops has been tested and evaluated and is therefore safe. Whereas these products, we know nothing about them. We're really operating in the dark. But I think, again, going back to your precautionary principle that you mentioned earlier, we should assume that these are at least as bad as cannabis. We should assume that they carry at least as many risks, if not more risks, than the nicotine vaping products that you've already highlighted. And I think we should be worried about them and more proactive in responding to the challenge that they pose.
The rest of the panel are going to join us now. We might field some questions from the chat and the audience, but just while they're joining, Professor Smyth, what advice would you have for a young person who is thinking of trying these products, and maybe B, a concerned parent whose child maybe has used the product?
From a parent's point of view, I guess that one of the things to note that while these are cannabis-related products, have cannabis-type effects, they don't smell like cannabis. So that distinctive smell that people might be aware of with cannabis, you're not going to notice that with these. Someone could be vaping these products in your sitting room with you, and you're thinking it's nicotine, and it's not. These drugs should be assumed to have the same risks as cannabis, and cannabis is definitely a drug to avoid if you're an adolescent. Yeah, just there's a wide array of worries, and again, to just really emphasize that point, just because something is sold in a shop does not mean it's tested, does not mean it's safe. I believe the burden of proof regarding safety and harm should lie with the retailers and the producers of these products. They should provide us with the evidence that these are perfectly safe. It shouldn't be up to health professionals like ourselves to provide evidence that they're actually harmful.
And if a young person or anybody indeed using one of these products feels that maybe they're becoming dependent on it, or they're experiencing effects that they didn't foresee, and that are undesirable, where should they go? Who should they call?
Certainly, you know, as I said, they're a component part of the presentations to our addiction treatment service. So whether a young adult or an under 18, there are at this point HSE addiction services around the country. Information about those can be obtained from the HSE Drug and Alcohol Helpline. There's also the drugs.ie website for people who are struggling with addiction issues, for people who are getting unpleasant mental health effects. If they're acute and a sudden bad reaction, I suppose, on a day, it's probably about going to an emergency department. If it's a more or a less acute issue, you could go to a GP, and the GP might determine whether or not you needed referral to mental health services.
Thanks very much. It's good to get some information about these products, because, as I say, it is a bit of a grey area for us. But anytime we speak publicly about e-cigarettes, these products seem to come up for us because they're definitely e-cigarette adjacent. They're almost put into the same category. So they're out there, and they've definitely proliferated the public psyche, so people know that they are there. So it's great to get some clear clear information and advice about them. We'll bring in the rest of the panel, and we'll just see if there's any questions in the chat for people.
Thanks a million, Ed. I'm conscious that we're over time, but we're happy to stay on and take some live questions if people are happy to stay with us. So there's a couple of questions in there. There's one related to e-cigarettes and how we came to that policy position, and on e-cigarettes. Paul, maybe if you want to take that one.
Yeah, thanks very much, Martina. Yeah, we've been trying to field the questions as they've been coming in, and there have been a number of questions in relation to e-cigarettes and the HSE's position on e-cigarettes. So we did work back a couple of years ago now to develop Ireland's first national stop smoking guidelines. We did that under the governance of the Department of Health's National Clinical Effectiveness Committee. And within that guideline development process, we looked at the evidence in terms of effectiveness, safety, wider impacts in relation to a wide range of different supports that could be used to help somebody stop smoking. So that includes behavioural support, that includes stop smoking medicines like nicotine replacement therapy, varenicline, etc. And then we also looked at e-cigarettes as well. And the sort of tests or framework that we used when we looked at e-cigarettes was the exact same as those that we used for the other technologies. So, you know, we tried to answer the questions. Does this technology work? Is it safe? Are there any wider concerns? And you can see within the National Stop Smoking Guideline, we have set out in very kind of comprehensive detail the discussion that we had around it. There's appendices where you can see the different sorts of evidence that we looked at and our discussion of that. The key piece of evidence that we looked at included the HICWA health technology assessment of stop smoking interventions. It also included a specially commissioned evidence review by the Health Research Board, and it also included at that point in time the current version of the Cochrane review. And when we looked at that, we found that there were some issues in terms of the certainty of the evidence around the effectiveness of e-cigarettes as a way of helping somebody stop smoking. In addition to looking at effectiveness, we also had to look at the issues around safety, and we had quite significant concerns when it came to the safety profile of e-cigarettes, because of course at the time there were issues in terms of the comprehensiveness of the regulatory framework here in Ireland, and then there's a lot of uncertainty in terms of what the long-term consequences will be for people's health of using e-cigarettes. And our concerns around safety were against a backdrop where the alternative is using a licensed and regulated stop smoking medicine. So, you know, I think we need to bear that in mind as well, you know, that there are alternatives available for people, including those alternatives now being available to people free of charge through our stop smoking services. So we felt the safety profile wasn't favorable. And then we had to look at some of those wider concerns, those wider implications. And, you know, as you've described, Martina, we've seen a lift off in terms of cigarettes across children and young people, because the behaviour is becoming increasingly normalised. So when we brought all that together, we arrived at a conclusion that we wouldn't, at this juncture, recommend e-cigarettes as a way of somebody to stop smoking. We have provided information in terms of how somebody might structure a conversation with somebody who's coming to services and is interested in making a stop smoking attempt with an e-cigarette. And of course, you know, any clinical guideline is always in a review process, so we'll be reviewing those recommendations in the short term, and we'll be back and we'll be looking at that evidence again. But in summary, you know, we did a very comprehensive, and I want to really emphasize as well, you know, very strictly governed kind of process to look at the evidence base around e-cigarettes when we developed those national stop smoking guidelines. Our guidelines went out to international peer review. Our guidelines went to the National Clinical Effectiveness Committee, where they were scrutinised, and ultimately those guidelines were endorsed by the Minister of Health. So, you know, that's our position in terms of e-cigarettes, and I think it's well founded in terms of our consideration of evidence across a number of different domains, not just effectiveness, but also safety and wider considerations. And I think all of that is kind of stands up when you look at the positions that other countries have taken as well.
Very good. Thanks very much. I'm aware that we're running over, and Professor Smyth, you may have to leave shortly. So thank you very much for your input, and thank you to all the panel for their input. We're going to kind of shorten the questions, but we have tried to answer the questions in the Q&A, and we'll try and respond as best we can. Ed, do you want to come in?
Yeah, there's a couple of questions in there. I can see at least 3 of them there around vaping education for young people, concern about vaping second level schools, concerning trend of work, considering how we can empower and motivate young people, peer-driven campaigns, etc. So we did put in via the estimates process this year for a prevention campaign for vaping. So we are funded to do that next year. So we'll be going to creative early next year to start designing what the tone and messaging of that campaign will look like. It's not going to be as big as Quit, in that there won't be a large TV ad campaign or things like that, but it will be very, very social heavy. So it'll be where the young people are, TikTok, Instagram, and it'll be very, very focus tested. So we'll spend the first part of next year developing the assets for social and things like that, focus testing it with young people and parents. And I would imagine that prevention campaign will be stood up in Q2 or Q3 next year. And hopefully we can increase our funding as the year goes on to make that more visible. But yes, that's certainly coming down the pipeline.
Absolutely. That's really good that we got that funding, and we look forward to working with our colleagues in comms to develop that campaign. A couple of questions in there about accessing the resources and whether or not you can access those videos. All of the stuff that we produce in Tobacco Free Ireland programme is freely available to everybody. So you know, it's published on the World Wide Web, so you can access it on Tobacco Free Ireland pages if you go into e-cigarette resources, and we put them in the chat, so anyone can download any of those assets to use in other jurisdictions. That's no problem. We don't hold on to any of those resources. And we have developed the first and second year lesson plans, and we're in the middle of developing third year lesson plans, and we've also out of school resources that could be used in school either. I know we might have some teachers and people who work with young people as well that might be interested in some of those assets and some of those resources. So I'm going to bring the session to a close. I want to thank everybody for their input, particularly all the panelists and all the speakers. And I really want to close out on by hearing another person who quit in Athy, Marelle Lawler Kelly, who was in access to service locally to me here actually in Athy, and just I think her story and her journey through quitting is just kind of heartwarming, and the impact it has in her life. So we'll just close out with that, and thank you very much for your attention.
Hi, I'm Marelle Lawler Kelly and I'm from Athy, and I did the Stop Smoking programme. I was hitting 40, so health was a big thing on my mind. And my mum had given up the cigarette a year before, so I said to myself, if she can do it, I can do it. Then I caught my young lad, which is 14, with a vape. So I couldn't be contradictory to him about smoking when myself and my husband smoked. So within doing the Stop Smoking programme, every day when I was turning my calendar, he had little notes wrote on it. Well done, Mum, keep going, Mum, so proud of you, Mum, which made me go further and was delighted with the support. It was local and accessible, and I could go there in between my shifts, which I found fantastic, and it was free. I loved the weekly support and the carbon monoxide pipe. I loved it so that I could actually see my progress. So I gave up the cigarettes, and then a week later my husband gave them up. We're much fitter. We're happier as a family. We spend more time together rather than myself and Anthony being out at the back door smoking. We've definitely more money, especially in these times, you need it. And one of the main things for me was my teeth. I wanted them to go back white, and they are slowly but surely. But I would say to anybody who wants to give up cigarettes is just do it. It's on your doorstep. You don't have to travel, and it's free. Why not do it?